We'll give a few moments yet for the groups to continue to sign in. Uh, Tonight's topic, of course, as you see on your screen, is integrating Articaine into your practice to improve success. Pleased to be with you tonight. My name is Stuart Lieblich. I practice here in Avon, Connecticut, practice of oral and maxillofacial surgery, and I'm on the teaching faculty at the University of Connecticut as well. I see a few more people jumping on. We'll give them a few minutes and a few moments, rather. Okay. I noticed on the website when you signed up there was a quite outdated picture of me on there, an old black and white one, so I put a more current one on there. In addition, I put a little shameless plug for a textbook that Robert Bozak and I have put out on anesthetic complications in the dental office. And in this text we not only go through issues associated with sedation and deep sedation / general anesthesia, but there's also quite a bit on the medical evaluation of patients that we treat in our dental practices, as well as some more information on local anesthesia as well. So with that, we'll go ahead and begin. Basically, I think local anesthetics are very interesting parts of our practice. They're obviously quite vital to what we do on a day-to-day basis. It's one of those agents and pharmacological agents that we tend to think the least about. And I do want to mention that we're looking out for what's called an ideal local anesthesia. So there have been some newer formulations of local anesthetics, and I'd like to do tonight is to go through some properties of what makes one local anesthetic potentially different from another and how we can integrate that into our practice. So certainly we are looking for an agent that will have fairly rapid onset. And of course we want profound local anesthesia, and that when patients come to us for operative dental procedures or surgical procedures, that they are fully anesthetized and do not feel any pain or discomfort during our care. We also want a predictable offset. In other words, we want the anesthetic agent to wear off. A possible exception, although it is still predictable, is that we may want a longer acting agent if we're doing surgical procedures that might have some postoperative pain or discomfort to be associated for the patient. So typical examples, of course, would be dental extractions, dental implant treatments, endodontic surgery, things such as that area. So again, will be a positive or less duration of action. We may want a longer acting agent or a shorter agent. We'll talk a little bit about how we choose those in our aspect. Naturally, we're very important to have patient safety as a forefront. Patients entrust to us their care, and it's important for us to maintain their safety. And of course, as our population tends to age, that more patients are on more medications, we need to be aware of how those medications and their own patients' medical conditions can interact with the local anesthetic agents that we administer. And of course, cost effectiveness is important. Certainly overhead costs make up a significant part of our dental practices, and things that we can do to reduce our costs while maintaining high levels of care are certainly always valuable adjuncts to our procedures. I do want to thank our sponsor tonight, Purell Pharma. They are formulations of Articaine, their trade name known as Orablock, and it comes in both 1 to 100,000 epinephrine as well as 1 to 200,000 epinephrine. And basically, I like to talk tonight a little bit about Articaine and how it interacts and works in our practices, and that if we're not using it as a routine agent, that perhaps we can integrate that into our practice. So basically, what makes one local anesthetic different from another? Well, we know that basically all local anesthetics are acid salts of weak bases, and that's a fairly complicated statement. It took me a long time to really wrap my arms around it, but we'll see a little bit how the local anesthetic gets from our dental cartridge through the tissues, through the nerve membrane to inside the nerve membrane, where it actually does block nerve conduction of the sensory nerves. Most of us are familiar with the two main types of local anesthetics, the ester types and the amide types. And you can see basically they just differ by what's called the intermediate chain. And this is the portion of the local anesthetic molecule that is responsible for the metabolism or the elimination of these substances from our system. We do need local anesthetics to be lipophilic, because basically it's important that the agents do go through the nerve membrane, and inside the nerve membrane being primarily a lipid molecules, to be able to flow through that where it acts inside the nerve to block conduction. The hydrophilic part, or the charged portion, will be important for the local anesthetic to be in solution so they can get from our dental cartridge to that lipophilic nerve membrane and cross inside the nerve to have its action. So if we look at our prototype local anesthetic, which is lidocaine, I think that we all know that's probably the agent that we use the most, that we're probably the most familiar with. And again, you can see the different molecular structure of it. It's three-dimensionally very important because it will affect how well it does move through that nerve membrane. And it's the benzene ring that allows it to be lipid soluble to cross into the nerve membrane. We contrast that a little bit with Articaine, and Articaine will be different because it will have a thiophene ring which has a sulfur group in here, and that actually improves the lipophilic properties of this so that it can diffuse through the nerve membrane. Another interesting thing about Articaine versus lidocaine is that it does have this additional ester group attached out here. And that ester group actually is responsible for some of its metabolism and breakdown. And we'll see how the ester metabolism of Articaine allows it to have a higher degree of safety. So it's interesting that although Articaine is technically an amide-type local anesthetic due to its formulation, however, the fact is that with the additional ester group, it is broken down by the plasma cholinesterases. And so these are enzymes that are out in our circulation in a very high percentage and population of those enzymes, so that the elimination and breakdown of Articaine is fairly rapid once it gets into central circulation. So again, we talk about our two classes, the amides, of course, lidocaine being our prototype or workhorse. Again, Articaine will fall in the amide class. We also talk about mepivacaine. Mepivacaine is an interesting agent because it is one of the least vasodilating agents, and it may actually act as a weak vasoconstrictor. We'll also see that Articaine, too, has little vasodilating activity as compared, for example, to lidocaine. Bupivacaine is the agent that is more highly protein-bound, and that will be responsible for its longer duration of action that we'll see. Prilocaine as well falls in the amide group as well. Now, historically in dentistry, we've always sort of avoided the ester class of local anesthetics, and the thought process being, well, they had tendency to create more allergic type responses in our patients. Whereas the amides, it's very rare, if ever, to truly show a true allergic reaction to the amide class of local anesthetics. But it's interesting that with the esters, we tend to use these quite routinely in our practices, and ceticaine, benzocaine, these are all agents that are actually ester-type local anesthetics. So, for example, if we were having an issue with allergic reactions that was clinically significant to the esters, all of us in our dental practices who use topical anesthetic agents would be seeing these much more frequently. So the issue of allergenicity of the esters is sort of overblown. However, in formulation-wise, the amide types will tend to be our better agents and be more appropriate for our use. One issue, of course, with the ester type, is particularly benzocaine, is that it can cause methemoglobinemia, which is a rare side effect which is also associated with prilocaine. So both these agents have been associated with methemoglobinemia. And that's a very rare problem, but it does occur when the metabolism of the local anesthetic molecule is shifted, and that does cause the binding of methemoglobin to the hemoglobin molecule, thereby preventing normal oxygen carbon dioxide shifting in the patient's status. Interesting because it's part of the metabolism of the agent, it typically doesn't show up for oftentimes an hour or two after the local anesthetic has been administered. So patients that do exhibit methemoglobinemia often happens an hour or two after when they've left the dental office already. So it is something where if you were using these agents, significant amounts of benzocaine, and some of these are found actually in topical agents such as Ambisol, for example, or other over-the-counter agents, that patients have developed methemoglobinemia, typically respiratory distress, dyspnea, or difficulty in breathing, somewhat similar to asthma-type problems, but they don't respond to the typical asthma treatments of bronchodilators, and when they go into the hospital, they're found actually to have issues associated with the methemoglobinemia. So let's look at the local anesthetics in general, what factors make one local anesthetic different from another. We're going to talk about these areas individually, but pKa, the chemical structure, will affect the rate of onset of the agent. The lipid solubility will affect how potent the agent is. Protein binding, as I mentioned earlier, will affect duration of action. And vasodilation activity, basically that's very important because it will affect the duration. The more highly vasodilator the local anesthetic agent is, the less duration of action, because as it dilates the blood vessels in the area, creates more circulation, the body's going to take that local anesthetic away from the nerve into the central circulation. Also too, if it's a very potent vasodilator, then we might have an increased potential for toxicity as a high enough agents of these local anesthetics get into the central circulation. So let's take a look at pKa to start with. So if we look at, for example, lidocaine, and lidocaine has a pKa of 7.9. Now, normal tissue pH is 7.4. So 7.9 does sound very close to 7.4. However, we're dealing with logarithmic numbers here. So basically, if we look at this rough example, if we inject 100 molecules of lidocaine into the tissues in this area, due to the pKa being 7.9 and the tissue pH of normal being 7.4, it's going to dissociate into the 75 to 25 ratio of those 100 molecules. So the 25 will be the uncharged, the 75 will be the charged particles. Now, the uncharged portion, or the lipid-philic portion, will then be able to cross the nerve membrane to get inside the nerve. Once inside the nerve, that 25 molecules is going to break down again into that same 75-25 ratio. So basically you have 18 of the charged portion and 7 that are uncharged. And it is the charged portion that will block the nerve conduction. So you see out of the 100 molecules, there's 18 available to block nerve conduction. Now, certainly as we pull these molecules across the nerve membrane, we're going to shift the equation towards the side, but this gives you a rough example, and therefore the closer the pKa of your anesthetic agent is to 7.4 or normal pH, the more of a 50-50 split you're going to get, and then therefore you'll have more molecules available to cross that nerve membrane. So if we make a chart of the local anesthetic molecule agents that are available for us to use, we look again here at lidocaine, which has a pKa of 7.9. Again, at normal pH, you're going to have 25% as the base form, uncharged, which can cross the nerve membrane, and therefore it takes about 2 to 4 minutes for lidocaine to be effective after it's administered to block a nerve conduction. If we look at some other agents, specifically Articaine, you can see its pKa is even lower, one of the lowest. Bupivacaine is actually the lowest that's commonly available for use. Here you see a higher percentage of base form available, and therefore, within 1 to 2, 3 minutes or so, Articaine will be effective at blocking the nerve conduction. In contrast, if we looked at Procaine or Novocaine, which was an ester-type local anesthetic, it had a very high pKa. You can see that only 2% was available in the base form at normal pH, and therefore it took a very long time for Procaine to be effective at blocking nerve conduction. So that's why I feel that pretty much it was eliminated from our use when lidocaine was developed, because obviously you're going to have much more rapid onset of action with lidocaine. Also, another agent to look at is bupivacaine, which is a long-acting agent. We'll talk more about why that is in a few minutes. But again, it has a higher pKa. Again, doesn't seem much different than 7.9, but again, talking about logarithmic numbers, you can see that only 18% is available in the base form, and therefore it takes 8 to 10 minutes if you're using bupivacaine as your agent for injection. Now, the next factor to look at in local anesthetic solutions is what's called the lipid solubility. And lipid solubility in a rough form is how well those molecules can cross the nerve membrane based on their three-dimensional structure. And the more highly lipid soluble the agent is, the more potent it will be, and therefore you'll have a faster effect. So if we take our two agents, Articaine and lidocaine, you can see that the lipid solubility is much higher for Articaine versus lidocaine, and this has to do again with the thiophene ring. So that thiophene ring does improve the lipid solubility of this molecule, making it more accessible to cross that nerve membrane to get inside the nerve and then attach to the nerve sites to block the nerve conduction. So again, we have a better use, better effectiveness with the Articaine in that situation. Now the third factor, as I mentioned, is protein binding. Now the proteins are out in the tissues, so tissues have a lot of proteins within tissues, and the local anesthetic molecules will stick to the tissues. The more highly protein bound the agent is, the longer duration of action you're going to get. So if we assign a value of say 65 to lidocaine, you can see it has a duration of action of around 90 minutes, whereas you can see that Articaine is much more highly protein bound, and therefore it's going to give you a much longer duration of action than even lidocaine will. So it's an agent to consider because it sticks to the tissue proteins. The other advantage of having the agents stay attached to the tissue proteins is that then they don't get into the central circulation, and then therefore there's a less systemic uptake of the agents as well too. So let's look for an example like this. This is a fairly common situation. We have teeth that are abscessed or infected. We may be electing to do endodontic treatment on this tooth, or do extraction, or even just drain the infection. And so here we're not dealing with a life-threatening infection. We have something that's very well localized. The body is walling it off quite well. But obviously we need to get the patient out of pain, get the infection under control, and then provide definitive care to this tooth. So if we look at infection, and sort of the rule of thumb has always been to say, well, when we have areas of infection, it lowers the pH. So again, our normal pH was 7.4. Say, for example, in this situation, the pH drops down to 6 in an area of infection. So instead of depositing the 100 molecules that we showed earlier, instead roughly depositing 1,000 molecules, you can see what happens here with the pKa of 7.9 of lidocaine, that only 10 molecules out of those 1,000 will be in the base form and therefore available to go through that nerve membrane, again that lipid membrane. Once it gets inside the nerve, this pH inside the nerve is very tightly controlled, so the pH will remain intracellularly or within the nerve sheath itself at 7.4. So we're going to again break down into that 75-25 ratio. So 7.5 molecules are now available to actually block the nerve conduction. So it shows you why it's much more difficult in situations of infection to get true or potent anesthesia. Now there are a lot of other factors that are going on in areas of infection besides just the fact that the pH is lower. We have other mediators of infection that are released by the tissues when there's infection, increase prostaglandins, and these things also tend to interfere with the binding of the local anesthetic molecule to the nerve receptor sites. So it may not just be as simple as a lower pH, but it's certainly one factor. So we'll talk about how we deal with that and compensating for infection. So first of all, we want to use an agent with a lower pKa that's available. So having something with a lower pKa, again, is going to allow more of those base molecules to be available, even with a lower tissue pH, to cross that nerve membrane. And again, in contrast with lidocaine, by using Articaine with a lower pKa of 7.8, we'll have more of those molecules available for our use. Also, we may want to consider using a higher concentration of local anesthetic. So again, Articaine comes prepared as a 4% solution versus the 2% solution of lidocaine. So here again we have twice the amount of molecules available per ml or cc to inject into the area, which again helps more of those molecules be available to cross that nerve membrane and block nerve conduction. So again, we can use 3% mepivacaine or 4% Articaine are good options when we have infection in the area. And also using an agent that's more protein bound, because again there's this kind of a push-pull when we inject a local anesthetic agent that the body, the systemic circulation, is going to be removing it from the site of action, taking it into the central circulation. But if it's more protein bound, it's going to stick to the tissue proteins in the site of the injection more vigorously and therefore potentially be available to give us a more profound local anesthetic blockade. So again, using an agent like Articaine versus lidocaine, you're going to have an agent that's much higher protein binding, so therefore it's going to stay in the area and be effective for us. So those two agents that have the highest protein binding, again, are bupivacaine and Articaine as well. And using an agent also with a higher lipid solubility is going to allow the molecules to cross that nerve membrane even better. And as we showed on the previous slide, that the thiophene ring of Articaine does make it much more lipid soluble versus lidocaine, and therefore allow it to have a higher effectiveness for us. So agents, also using an agent as less of a vasodilator. As I mentioned, most of our local anesthetics are fairly potent vasodilators, so if you assign an arbitrary value of 1.0 to lidocaine, you can see that Articaine is almost half, or say 3/4 less of a vasodilator than lidocaine is, also consistent with mepivacaine. And so we know mepivacaine is often used as an agent without a vasoconstrictor due to the fact that it may have some weak vasoconstricting activities, as does Articaine as well. Other agents are more potent vasodilators, particularly bupivacaine, twice as much as lidocaine. So therefore, although it is more highly protein bound, it's a more potent molecule, but it does cause more vasodilation. So typically we'll find in areas of infection a more profound local anesthetic using agents such as Articaine in that instance. So let's step back a little bit and look at the agents that are out there and maybe why we've changed and moved ahead. First of all, Procaine or Novocaine was the least toxic of all the local anesthetic agents. Again, it was an ester type, so it did not require hepatic metabolism such as the amides do, so therefore it was broken down by the plasma cholinesterases, so your body, once it got into the systemic circulation, could break down or inactivate this agent at a fairly rapid pace. There is this concern about ester-associated allergic reactions. I kind of give that a plus minus because, again, as I mentioned earlier, we're using esters left and right, particularly with benzocaine. The main problem, though, with Procaine, it had a very long onset. Remember, its pKa was 9.1, so it took a very long time, 15 minutes or so, for it to become effective. And because it's a fairly potent vasodilator, it had a fairly short duration of action as well. So therefore, by the time the patient was getting numb, the local anesthetic effects were pretty much wearing off. And therefore, getting good, profound local anesthesia with Procaine was usually not that successful. Lidocaine, as I mentioned, is sort of our workhorse agent that, fairly common agent used in dental practices and one that we sort of compare all other agents to. It has a fairly fast onset, decent duration of action, but again, it's a fairly potent vasodilator, so it does require vasoconstrictors for pulpal anesthesia. And using lidocaine plain is fairly ineffective. Sometimes we use it for soft tissue wounds, for suturing things, but in general, lidocaine should always be combined with a vasoconstrictor to keep it in its site of action and to reduce the systemic uptake, which reduces the potential toxic reactions associated with it. Mepivacaine, 3%, is a little vasodilating properties, may act as a weak vasoconstrictor. What's nice about it, because it does not have a vasoconstrictor mixed in with it, there's less pain on injection. And as we talk about dealing with the pain of injection, which of course is a concern for us and primarily our patients, of course, is that the fact that the vasoconstrictors, such as epinephrine, have to be kept in an acidic solution to maintain the stability of the epinephrine molecule. And so therefore, this stinging and burning on injection is not so much the needle puncturing the mucosa, but the actual agent themselves with a lower pH causing a little bit of local irritation to the tissues. So by therefore using an agent without a vasoconstrictor, therefore there's less pain on injection. So patients often report less pain with that. It's effective but fairly short duration of action for pulpal anesthesia. So again, if you are using it, you sort of need to move fairly quickly with its use. Now, occasionally, it goes off and on the market is mepivacaine with levonorepinephrine. It's a 2% solution versus the normal 3% that you get with mepivacaine. The onset and duration of action will be consistent with lidocaine and epinephrine. There is an increased interaction with the tricyclic antidepressant drugs with the use of levonorepinephrine versus epinephrine, so you do have to be cautious with that. There potentially is a benefit that there's decreased interaction with the patients taking nonspecific beta blockers. So most beta blockers that patients take now for cardiac issues and hypertension will be more specific, such as metoprolol and the other agents, whereas Inderal or propranolol was an agent that was a nonspecific beta blocker. And so with those nonspecific beta blockers, we had to be a little bit more cautious with the use of epinephrine. But with the specific beta blockers, we can use a fairly standard doses of epinephrine for those patients. The main problem with this drug is that you're getting a subpotent concentration of mepivacaine. So mepivacaine does not have the same degree of potency as does lidocaine even, and therefore using it in a 2% solution would actually reduce the number of molecules that were available, and therefore it did not become quite as effective. Prilocaine, again, as we'll see with Articaine, that you can use it with or without epinephrine, that the duration of block seems to be about the same. Good onset of action and efficacy and compared with lidocaine with epinephrine. But with prilocaine, you do have this risk of methemoglobemia, as I mentioned earlier. So it is something that does come and go. There seems to be certain groups, particularly in our area, at least the pediatric dentists, that like to use prilocaine, and every once in a while they'll have a child that will develop the methemoglobemia an hour or two after treatment. So let's focus a little bit on Articaine. As I mentioned, it is still an amide, but it's one of the least toxic of all the amides. And the reason being is, again, it has that ester chains, which does allow the initial deactivation and starting of the elimination phase of the Articaine once it gets into the central circulation. So it does not require as much of the hepatic or liver metabolism as some of the other agents. Again, that lower pKa is going to give you a faster onset of action, which certainly is a very positive thing. Increased safety due to this plasma metabolism, a higher potency, again, versus lidocaine, again, due to that thiophene ring, which allows it to move through that lipid nerve membrane quite well. And at this stage, even though it's a similar in chemical structure as to prilocaine, there have not been any reported cases of methemoglobemia associated with the use of Articaine as a local anesthetic agent. So it does have a lot of very positive factors for us. So let's deal with this. This is probably the most complicated situation that we all face in dentistry. Obviously, we deal with some adults that have significant anxiety about their dental procedures, but usually we can reason with them and sometimes get them through the local anesthetic injection. But the screaming or crying child that, obviously we need perhaps to do some extractions or some small restorations, or certainly get our blood pressures up as much as the child, and can be fairly difficult to treat. So basically, one of the things that the child is concerned about, of course, is the pain of injection. And now we can use the topical agents. We'll talk a little bit about that. But as I mentioned earlier, it's primarily associated with the pH of the solution. So using a 25 gauge or a 30 gauge needle usually is not distinguishable in the amount of pain. And in some of the best laboratory animals, which of course are dental students, when they were studied, they could not tell the difference on the gauge of the needle whether a 25 or a 27 gauge needle was used. But it does significantly associate with the pH of the solution. So again, the lower pH, the more acidic it is, the more it's going to sting and burn potentially on injection for the patient. So epinephrine, as I mentioned, needs that acid environment. It's not that the local anesthetic manufacturers are trying to get us to hurt our patients, but they need to provide stability so that the epinephrine remains its effectiveness for us when we're using it for injection. Now, another thing that will affect the discomfort that the patient has will be your speed of injection. And so there are some fairly elegant mechanical devices that will slowly inject the agent for us. I'll show you some mechanical ones that are a little bit less expensive and easy to use. And basically, if we can reduce the speed of injection, we can reduce the amount of pain that we get associated with the injection as well. Certainly the volume of injection is important, particularly if we're giving it into a very tightly closed space, such as on the palatal mucosa. We know we can't put that same volume of fluid as we can in the buccal mucosa or the vestibular areas. So we do want to be cautious about the volume of injection that we give. And again, type of tissue, we know that the keratinized tissue, such as on the palate, do not respond very well to the topical anesthetic agents. We still put some topical on the palate when we give a palatal injection because we know it's going to hurt the patient. If we didn't put the paste there, they would kind of be frustrated, like, well, why, the one on the outside didn't hurt me because he put the paste there, but he didn't put any paste on the palate, and that one really hurt. So I do put topical paste on the palate, but primarily the way to reduce some discomfort with palatal injections is to put pressure on the area. So again, using the same cotton applicator swab, putting pressure on there for about 5 to 15 seconds will cause some local blanching, reduce a little bit of the sensitivity in the area, and then again, using a small amount of the local anesthetic solution will often be effective. And if you use a dull needle with a barbed end, so depending on your block technique for inferior alveolar nerve injections, a lot of people will actually go in until they touch bone, then back up a little bit, aspirate, and inject. And if you use that same needle over and over again, say you're doing 4 third molar cases or multiple extractions in multiple quadrants of dentistry for your patient, those needles do tend to get barbed, and it looks like a little fish hook when you look at it under a microscope. So, local anesthetic needles are fairly inexpensive. It's a good idea after 2 or 3 injections in mucosa, or if you really felt like you hit the bone fairly hard, to switch it out for a new one. Patients will have less pain, but you'll also create less tissue damage. And sometimes patients will have post-injection trismus, where difficulty in opening, which is thought probably due to some local tissue damage, usually due to the barbed end or the trauma from the needle itself. So what is the pain associated with? The gauge of the needle, as I mentioned, you can't really detect the difference between a 25 and a 27. Obviously, one benefit of using a 25 or a thicker needle is that there's less risk for needle breakage. The temperature of solution, warming the local anesthetic agents really doesn't help. Leaving them in these warming solutions for long periods of time can actually start to break down the local anesthetic molecules. So again, we don't recommend warming the solution. The number of injections doesn't matter as well too. And so there's this tendency to want to put a large volume of local anesthetic solution with one injection, maybe at a fairly rapid rate, because you're worried you're not going to be able to inject the child again if they're overly reactive. But instead, as we'll talk about, giving a very small amount and giving multiple injections in the area of smaller volumes will actually reduce the amount of pain and allow you to get enough local anesthetic solution into your site to get good, profound local anesthesia for your patient. So let's take a look at what our armamentarium is. Of course, we have our topical agent, typically administered on a Q-tip or cotton applicator. We want to dry the area first. So before you paint the paste on there, take a dry piece of gauze and dry the area, a dry piece of gauze of course, but dry the area of the mucosa. That will, and you're wiping it off as well too, remove some of the normal coating that the tissues produce to protect themselves, and therefore allows your topical anesthetic agent to be more effective. Place a topical in there. Again, with young children, you can discuss with them the flavors. Our local anesthetic suppliers or topical agents typically provide very many different flavors. We just have this one flavor, and I always ask the kid, do they want raspberry, banana, or pineapple? And they pick one, and we use the same paste, and no matter what they pick, I said, yeah, that's what we chose, and they intuitively think that's actually the one we gave them. We'll then inject a little bit of local anesthetic solution into the area and then follow it up with the additional agent to get our profound block. Now, as I mentioned earlier, one of the issues has to do with needle gauge. Now, one thing, obviously, if we come to a child with this very long needle and syringe apparatus, I think that's going to create some significant apprehension in the child. The other issue is controlling the volume of injection that we give at one time. So by using one of these small devices such as this, each little click or depression of this lever here dispenses 0.1 ml of solution. So this way it controls very nicely a small volume of agent to be administered. And you can use a 30 gauge needle on this. It's a short needle. We don't want to use a long 30 gauge or even a long 27, because if the child moves or fights us, that could break off and that can create a problem. So use a short needle. Obviously you don't want to bend the needle. In this syringe here, I'll usually have some plain 3% mepivacaine. So again, the idea of giving a little bit of an injection with the mepivacaine first does not have the vasoconstrictor. It'll have a more normal pH of the solution. Therefore, it won't sting and burn quite as much. And what I tell the child, say, is listen for the click noise and hit it one click and it'll be a little click. And really, if you place good topical anesthesia in the area, they won't feel that injection at all. And then waiting a few minutes for the mepivacaine to anesthetize the local tissues, so then we can go back with our Articaine to get an appropriate volume and number of molecules in that area to get good profound local anesthesia. Just a little close-up of the device here. So again, dealing with this kid, start again with good topical anesthesia. Again, we all have our different bedside manners or dealing with chairside situations. And, I will say right up front that not every child will allow me to give a local anesthetic injection. And so we're kind of fortunate in oral surgery that we have other means of anesthesia and sedative techniques that we can use. But in general, if possible, we like to stay with local anesthesia, perhaps local and nitrous oxide. It's the least risky for the child and allows us to do these short procedures usually very effectively with no discomfort to the patient. So again, starting with some topical anesthesia, discussing with the child the different flavors, distracting them, whatever technique you use. Again, placing the small wheel of mepivacaine into the vestibular area. Again, waiting a few moments for that mepivacaine to take effect. Its pKa is fairly low as well, so therefore we don't have to wait too long, usually 2 or 3 minutes. We'll give you reasonable soft tissue anesthesia in that area, so then we can follow it up with our Articaine injection. Then we'll infiltrate the Articaine for our maxillary infiltration. Again, using that device, or if the child has been relatively calm, we can use a more standard type of a syringe with a short needle. Typically, we don't need the really long needles in children, even for block injections. Supplement the injection into the papilla. I'll show you a little bit about that in a minute. And then also, by injecting the Articaine into the furcation area from the buccal side after we've already anesthetized the soft tissues, allows us to get good pulpal anesthesia, as well as also the effectiveness of the Articaine to diffuse through the tissues, and then even to allow us to extract teeth without having to give a secondary palatal injection. And so whatever we can do to avoid the palatal injections obviously is going to be a very positive outcome. So if you want to avoid the palatal injection, you have to do a couple of things. First of all, get enough quantity of the local anesthetic in the area. We need to give it enough time for it to diffuse through the tissues and allowing that movement through there. Now in children, even in the mandible, their bone will be softer and more porous, so therefore there's a better diffusibility of the local anesthetic agents through the bone itself to block some of the local nerve fibers even for doing extractions. So this is an example here. So we've put a wheel of the mepivacaine up in this area here. We've waited a few minutes for it to be effective. We then come back, give a larger quantity of Articaine up in this area, wait another 2 or 3 minutes for that to become effective, and then say we're going to extract this primary canine tooth, then actually injecting directly into the PDL region of the tooth. And again, by depressing this, you're getting a good flow of the Articaine into this area. The bone is relatively porous. We'll see some blanching of the tissues, and that indicates that the solution is getting into the area. The vasoconstrictor and actually the solution itself will cause a little bit of local blanching. Waiting a few moments for that to take effect, giving another injection. And so even though I'm taking out this single primary tooth, I might give 4 or 5 individual little injections into this area instead of trying to give one larger quantity all at one time. Again, the Articaine has a much higher potency, so it's going to diffuse through the nerve membranes better. It's going to also work its way through this area and allow it to be effective without having to give a secondary injection. Now again, in pediatric cases, for mandibular cases, again, we're dealing now also with, again, more porous bone. So say we're taking out this lower primary canine here. Again, the same principle, topical anesthesia. You can see a little bit of ballooning of the vestibular tissues here. This is again followed up from the initial wheel of the mepivacaine, followed by Articaine for the infiltration, and then secondary injections around the PDL area. If this was a molar tooth, let's say this is a primary molar, I would actually be injecting directly into the furcation region. So say there's a mesial and a distal root, placing this directly through, and you can actually puncture the bone in some cases. It's fairly thin. Using a short needle allows you to get a little bit more leverage. And then once we get into the intraosseous area, then we can also inject 0.1 to 0.2 mLs of the solution, and that will really diffuse very, very well. So again, we don't have to give a full block. The patient will have perhaps just localized lip signs, maybe not very significant ones, so we don't worry about lip biting after the procedure. We don't have to give the block, and in the maxilla we can avoid having to get palatal injections. So what about older patients? They also make up an important part of our practices. Are there any differences from the child? Well, typically they can be hopefully more cooperative. They can be more rational in reasons, that they understand that once we block the area, that they won't have any pain, that we can perform our operative dental procedures or surgical procedures for them. But we need to appreciate the fact that geriatric patients are different than young adults or adult patients. There's reduced organ function, so their hepatic metabolism, renal functions may not be quite as good. So again, using an agent that doesn't rely as much on hepatic breakdowns such as lidocaine will help the patient. They have less lean body mass, so have less area to disperse the local anesthetic solution through their body, less total body water. So again, greater concern with hepatic metabolism agents such as lidocaine, as opposed to agents that are broken down by the plasma cholinesterases, which again is which Articaine does have one of its primary means of elimination and inactivation. So how do we improve safety? Basically, we have to be concerned about risks of toxicity and overdosage. So it's not a common problem, fortunately, in that local anesthetics are fairly safe molecules to work with, but particularly in pediatric populations, and I reference this article by Goodson and Moore, and basically they were actually looking at pediatric sedation cases many years ago and found that it was not so much the fact that the child got some sedative agents, including narcotics and opioids, that created the life-threatening reactions, but it was actually the local anesthetic overdoses. So when we deal with children, it's very important that we understand that they need a reduction in total doses of local anesthetic agents, or use an agent that's broken down a little bit more quickly. Again, that's one advantage of using Articaine over lidocaine in these cases. So our risk associated with toxic overdoses of local anesthetics, when you have a child, and unfortunately childhood obesity is a significant problem, so therefore you need to really look at what would their lean body weight really be when you start calculating your milligram per kilogram doses of your local anesthetic solutions. So what makes local anesthetics more toxic is that if you have a pH change, so if the patient has a lower pH, so if they're not breathing well because they've gotten some narcotic medications, that's going to lower the overall pH, make more of the local anesthetic available, and potentially increase the toxicity of the agent. So what is the elimination half-life? Basically the time for half of the drug to have half of its activity eliminated. It's based on inherent properties of the drug itself. depends on the site of elimination. So if we think about liver metabolism, hepatic metabolism, we think acetaminophen or Tylenol. We know that unfortunately that there are high instances of toxic overdoses of acetaminophen, so even a drug that we think of very safe as being Tylenol can cause severe hepatic damage in some patients. Now also what affects liver metabolism oftentimes is patients who have had chronic alcoholism. They'll have cirrhosis of the liver, so their liver doesn't function as well. Patients who have sometimes suffered hepatitis, whether hepatitis A, B, or C, can also have liver damage as well too. So most of our amide local anesthetics, lidocaine, mepivacaine, for example, as well as bupivacaine, do have primarily a hepatic mechanism for elimination. And so therefore, patients who have any types of hepatic or other type of compromise, we might be a little bit more concerned about using lidocaine or mepivacaine in these patients, and therefore Articaine might be a very good option for you. Now if we look at the elimination half-life, Articaine versus lidocaine, you can see here that Articaine is eliminated much more rapidly than lidocaine. Again, it goes back to the fact that it doesn't require a hepatic metabolism, but the plasma cholinesterases. So majority of Articaine is eliminated within 30 minutes, and that tells us as well too that if we had a very long procedure, we're doing multiple quadrants of dentistry, the patients are starting to have return of sensitivity when we're doing our operative dentistry, that by using an agent that's more rapidly administered, or eliminated rather, we can administer more of that local anesthetic agent, and so you'll have 4.5 times faster elimination of Articaine versus lidocaine. So might be a good indication for its use during long operative dental cases. So what about failures of local anesthetic agents? Basically, why does it not work? We talked a little bit about infection. Sometimes we can have what's called tachyphylaxis, which is an increasing acute tolerance, not someone who's had a drug taken for long periods of time, but an example of local anesthetic tachyphylaxis would be, say, you gave one injection, it lasted for about 45 minutes, and then they had discomfort, you inject them again, it only lasts for 30 minutes, and then that wears off, and then a third injection only lasts for about 10 minutes. So it has to do probably with local tissue reactions. Maybe there's some localized bleeding in the area that you're re-injecting into, therefore it's more rapidly being taken back up into the central circulation or diluted. It may also be due to a decreased pH in the area as well too, due to the epinephrine components. So edema, local hemorrhage, increase in sodium in the area as well too is a factor. Now what about anatomical variations? We'll talk a few moments about that, what makes one patient different than another. There's this cross innervation, so we know, especially as we get to the anterior, there's nerve innervation from the right side crossing over to the left side. But we also know too that when we're dealing with the anterior mandible that the bone is fairly porous, and the reason being is that the mentalis or the chin muscles actually attach directly to the bone, creating little porosities in the bone. So by infiltrating in this area, even in adult patients where the cortical bone is a little bit more denser, we can still get local anesthetic effects without having to give a nerve block. And again, by choosing an agent that has better potency and diffuses better, such as Articaine, we may get an increased improvement and success of our local anesthetic injections. Some patients can have bifid canals. It's not always picked up very easily, so it is possible we gave an inferior nerve block and placed the agent right here. This portion of the nerve might run through the bone and come out here onto the lip and chin, so a patient might have fairly profound lip and chin signs, but yet still have discomfort in the site of our surgery. So sometimes giving a second injection more posteriorly or higher up may help obviate the problem if your inferior alveolar nerve block is not totally successful, even though the patient has lip signs. Now along the lingual side of the mandible, there's the mylohyoid nerve. Now the mylohyoid nerve is primarily a motor nerve to the mylohyoid muscle and the anterior belly of the digastric. Sometimes though it tracks along the medial side of the mandible and can carry with it some sensory fibers, particularly to the lingual aspects of the first and second molars, including the pulpal tissues. And we know sometimes we'll actually see the root apices of the second molars or even first molars very close to the lingual plate. So sometimes, again, you may have given a very successful inferior alveolar nerve block. The patient has very profound lip and chin signs, but you start to do your operative dental procedure on the molar and they have significant pain. So by giving a second injection along the medial surface of the mandible, just adjacent to the tissue and bone itself, we can block this nerve conduction if some fibers are coming through here. As well, again, using Articaine, which diffuses very well, is a good agent in this indication, because then you should get more diffusion through the bone and getting more nerve blockade. Basically, what have increased plasma levels if you give too much, which is an iatrogenic error. We didn't compensate for the child's weight or the adult patient's weight, especially patients at age extremes. They're very young, they're very old. Small patients, sick patients have decreased plasma protein, so patients are not healthy. They may have higher toxic levels or increased susceptibility to the toxicity of our local anesthetic agents. And some patients just hyper-respond to a local anesthetic agent as well. Again, by using agents without vasoconstrictors, they're going to be more rapidly uptaken into the circulation and can have a higher rate of toxicity occurring. We talked a little bit about delayed metabolism, particularly patients who have hepatic disease, liver disease patients. So again, using something broken down by the plasma cholinesterases will help avoid those types of problems. And we can give an intravascular injection. This is often the fact we didn't aspirate or we didn't aspirate well, and it's important to continuously aspirate because we know the needle tip does move a little bit as we inject, and so we might have been outside the nerve vessel at first, had a negative aspiration, but then as we push the plunger in, that may push the needle tip in, deeper slightly into the tissue, end up inside a vein or an artery, and then give an inadvertent intravascular injection. Again, by injecting slowly, we should not have a true toxic reaction, but the patient may start to get an epinephrine reaction as it's picked up very quickly by the central circulation. So LAST is acronym for local anesthetic systemic toxicity. Again, we really need to have elevated plasma levels, and basically what happens is the anesthetic will act not in our site of action, but actually in the central nervous system in the brain. And typically it's sequenced and stereotypical. In other words, when local anesthetic molecules cross the lipids of the blood-brain barrier and start to create conduction changes there, they tend to block the inhibitory nerves first, and therefore the patient may first exacerbate or present itself with a seizure. So the excitatory nerves are working unopposed, and then the patient has a seizure. So basically, excitatory nerves are blocked at a higher level, so we're blocking the inhibitory nerves first, and therefore allowing a seizure to develop. So often early excitation, then depression. Basically, if depression gets severe enough, they can actually stop breathing. You also can start to block the nerve conduction in the heart. Of course, we know that the transmission of neurological impulses through the heart creates the cardiac conduction. Local anesthetics can block nerve conduction in the heart. So therefore, you want to make sure that we don't get into those toxic levels there. In the vasculature, we'll get some vasodilation. So clinical signs of local anesthetic systemic toxicity. Seizures are primary signs. Sometimes patients can have dizziness or confusion, agitation, and high enough can be loss of consciousness. So we take these signs and symptoms importantly after we inject a local anesthetic to make sure that we're not developing it, and that if we do start to see these signs, then we obviously need to stop our injection, support the patient. They may need supplemental oxygen to help them get through until the local anesthetic concentration decreases enough that the patient returns back to baseline. Now we know if we put the needle in the wrong part, getting a nerve block can be difficult. It's an anatomically blind injection. We're palpating the mandible, injecting posteriorly, aspirating because there's some major vessels. If we're too posteriorly, we can actually get into the parotid capsule, which can cause some facial nerve weakness. That is sometimes an occurrence. If we're too medial, then we may just inject into the medial pterygoid muscle, which can sometimes contribute to some trismus. But we do ideally block the inferior alveolar nerve as well as the lingual nerves, so that we can provide operative and surgical care for our patients. So here's always the dilemma. The lip is numb, but the tooth is not. Why does that happen? Well, basically there's a central core theory that says that the nerve axons that are in the middle of the nerve may take longer to anesthetize than the ones that are more superficially located, and sometimes the more superficial ones are the ones that go to the lip and chin, whereas the central ones may actually go into the teeth themselves. Other nerves that may be supplying the molar teeth, particularly the lingual nerve or the mylohyoid nerve, as we mentioned. Basically, the local never gets there as well due to the fact. And there may be other mediators that reduce the thresholds of excitability. So basically, in areas of infection, as I mentioned earlier, we're elucidating a lot of other agents in sites of infection, tumor necrosis factor, prostaglandins, that can also block or reduce the effectiveness of our local anesthetic blockade. And also tends to be this upregulation of sodium channels. So it's not as simple in areas of infection as just lower pH, but that may have one important factor. So what we can do, we can re-inject. Sometimes that's successful. We can try a different anesthetic. Again, I'm going to be thinking here about using an agent that's more potent. We can block some of these accessory nerves. We mentioned the mylohyoid nerve along the lingual side, maybe also injecting along the buccal aspect of the tooth if you gave a block. And again, infiltrating Articaine on the buccal, we're going to have a better diffusibility, higher potency than we're going to see then with lidocaine as well. We can inject into the periodontal ligament. There's also the option of using the intraosseous injections. They're little drill devices that actually perforate the bone and then allow you to inject into the intraosseous area between the teeth. Those are very effective ways of getting a local anesthetic into the region. However, when you give an injection intraosseously, it's also a very rapid way to get it into the central circulation. So do be cautious about the amount of drug that you give and also the speed of injection as well. What doesn't work is using more local anesthetic or more vasoconstrictor. We're probably reducing the pH even more. And using a more potent anesthetic, as I mentioned, is the way to go about it. So if you inject into a blood vessel, we know from an artery it's going to go away from the heart into the tissue, so we might start to see some blanching. Sometimes we can see hematoma formation. Again, it doesn't mean we use bad technique. It just means the blood vessels were there. They are sometimes nicked with the injection and then cause localized bleeding, particularly in the pterygoid plexus area where the tissues are looser and it's less able to create pressure against the bleeding vessel to cause it to spontaneously stop. So question is here, did the doctor do anything wrong? No, that's not what occurred, just that the patient had some vessels in the area. And the way to manage these is with ice for the first 24 hours, followed up with heat for the next 24 hours to hopefully dissipate this area. But they can get some fairly significant bruising or ecchymosis. Antibiotics really are not going to be very valuable because the bleeding that takes place has very little bacteria around it. And also when you have an area of hematoma like this, you're not really getting the the antibiotic into that area very predictably. Some blanching here from the epinephrine and maxillary injections or even mandibular blocks. Sometimes patients will start to complain of some eye pain. Now, of course, the important thing to recognize is that epinephrine is a very labile molecule, so within 2 or 3 minutes it will start to break down and be inactivated by the body's natural enzymes. So we don't need to do much about it. We just need to observe the patient to warn them that this is a temporary effect. It's due to the vasoconstrictor. That's an important part of our local anesthetic agent. Does not mean that the patient has a sensitivity or an allergy to the epinephrine, because epinephrine is an important component and we don't want to label that as a problem for the patient because it does negatively affect their dental care down the road. Again, here's some more blanching over here. It can be fairly impressive to see, and you can see carried up through one of the ocular vessels, the infraorbital region as well, supraorbital, causing the blanching in that area. So what about nerve injuries? And the concern is here when we talk about persistent paresthesia or anesthesia that occurs for a longer duration than the local anesthetic molecules that we want it to last. So sometimes 2, 3, 4 days later, a patient says they're still numb or have some anesthesia in the area, and obviously very disconcerting to the patient as well as us as well. Now, any local anesthetic solution can cause that as an issue. Now, the cause of it is not really well defined, and there are a lot of different thoughts at what can cause it. It may be due to needle trauma itself, the needle actually damaging the epineurium. We know, for example, that the lingual nerve has a higher incidence of persistent paresthetic injuries than does the inferior alveolar nerve. And the thought being is that the lingual nerve is located a bit more superficially. It's not contained within the bone, and so therefore it may be more susceptible to the needle damage. There may be some specific neurotoxicity of the local anesthetic agent itself, may be also associated with higher concentration agents, but again, this goes back and forth, and it's not reliably been reproduced as the sole cause of the problem. Again, I mentioned the lingual nerve is a higher frequency of incidence than the inferior alveolar nerve. And so the key thing is that if we're potentially close to where the nerve is with our needle tip, and again, it doesn't mean the doctor used bad technique, and in fact their technique was quite good if they got the needle very close to where the nerve should be, because we are giving these injections somewhat blindly. And so if the patient does respond by having electrical pain, and actually it happened to myself during a dental injection, the needle must have touched or rubbed against my lingual nerve, and it literally felt like I was sticking my tongue inside of a light socket. So naturally, I have a fairly vigorous response. I told my dentist. She immediately stopped the injection at that point, removed the needle from the tissue, and then reinserted it in a different direction. But by not injecting any more at that time, if the needle was within the nerve sheath, That would reduce the local trauma to the area potentially, as well as the fact by not injecting that should the needle get close to the nerve again on the second injection, then at least I would not be numb, so I could again report the sensation, and then therefore hopefully the nerve would not be damaged with the injection. So we always document the occurrence that there was electrical sensation, the injection was immediately stopped, the needle removed and repositioned without any further signs of discomfort for the patient. Now I'll just finish up with broken needles, never bend needles. Some people say 3 bends and they'll break every time. Again, particularly with pediatric patients using smaller gauge needles, there's a higher incidence of breakage. In and out, basically in a straight line. Don't bury the needle to the hub. If you need a longer needle, then get out a longer needle. Don't bury it in there. Smaller gauges are certainly easier to break. That all the needle breakage injuries have been with 27 gauge or higher number needles. I've not seen any reports of 25 gauge needles having broken within tissues. So avoid the use of 30 gauge needles for mandibular blocks, especially long ones. Keep calm should it happen. The key is that if it does break, to not remove your hand that you're using to retract with. So most of us are right-handed doctors. We inject with our right hand. We're retracting the tissue with our left hand. Say the needle were to break off with our right hand, throw the cartridge and needle and the syringe down. You'll still see the portion of the needle sticking out, and then you can grasp it with a hemostat. But if you let go with your retracting hand, your left hand, then the tissue will kind of envelop that needle tip, and then it is literally a needle within a haystack. You do need to get out those needles. They do require mandatory retrieval. Here's an example of a patient referred to us for a needle that was broken off here. And these are not something that can typically be done in an office setting, but they do involve going into the hospital, getting fluoroscopy, doing under radiographic guidance, locating the needle, grasping it, and then going ahead and removing it. So cases that do take a little bit of time to deal with. So to summarize, I say local anesthetics are very routine parts of our practice. They're usually, if not most of the times, very successful. Obviously, we could not do most of our dentistry without good local anesthesia. Failures do occur. In general, I don't think it's the doctor's fault. There's a lot of anatomical issues from one patient to the next. Usually, they're without major immediate side effects. We know that some of the ones we can see are syncope, just due to the stress of the injection, the epinephrine reaction, again, that fight or flight or tachycardia. Again, we don't want to tell the patient they're allergic to the epinephrine. It'll just reassure them, tell them it will pass within the next 2 or 3 minutes, allow them to sit up, calm them down, and then that will typically be it. Seizures, obviously, with a local anesthetic overdose. Again, allergic reaction, I've not really seen that much significant documentation of local anesthetic with the amide types that we use. Again, usually without major long-term side effects. Again, post-injection trismus, the patient says the next 2 or 3 days they can't open their mouth. So in those cases, they're probably due to injection trauma. We want to work on stretching exercises because if they don't start opening their mouth, the muscles will fibrose down and be very difficult. And then we talked about persistent neurosensory changes. Again, a very uncommon side effect with any of the local anesthetic solutions that we're using, but ones that do occur. Again, patients need to be observed and monitored for those types of injuries and referred if necessary. So putting it all together with Articaine, why are we using that? First of all, we have a higher concentration of 4% solution versus our 2% lidocaine, so we're getting twice as many molecules per ml of solution. Rapid onset of action, the PK is closer to our pH. Improved safety because it's broken down by the plasma cholinesterases. Fairly rapid elimination, so we can re-eject again after 30 minutes. Higher protein binding, less of a vasodilator. And again, this higher potency really allows us to have a better effect of the agent in our sites. So I want to thank you again for taking time, and thank again Perel Pharma, the maker of Orablock, for sponsoring this webinar. We can take some questions now, so I see the questions have come there. So one of the questions was, do we use Articaine for inferior alveolar nerve blocks in adults or in children? So again, there is that concern about the persistent anesthesia that can last for that. And what I will do is typically use a lidocaine with epinephrine for my block. If I'm doing an extraction, I'll use a long-acting agent like bupivacaine. And then I will inject Articaine as an infiltration around my surgical site. And if the patient does not have profound local anesthesia after waiting appropriate time, then I will go back and use Articaine for my inferior alveolar nerve block. I think there's a lot of myth out there that we cannot use Articaine, but it actually is a good agent for that, and in those cases I've been able to be successful, with that. There's a comment here that The doctor says his or her clinical experience supports that prior drug users have a slower onset of action for dental anesthesia and require more. So that's an interesting thing. So what types of patients could we say? Well, first of all, certain drugs that patients take, such as the SSRIs for psychiatric issues, those have been associated with potentially making it more difficult to get profound local anesthesia and take a longer time. And again, one thing I would use, again, in those patients is, again, an agent with a higher potency and higher concentration. So I think I would think about Articaine in those cases as well, too. So it was a question about, can I reiterate the precautions about injecting intraosseously? So intraosseous injections are quite interesting because in resuscitation of patients who are in cardiac arrest or what have you, and we cannot get an IV, we actually will have a device to create an intraosseous injection into the tibia, which allows us to inject drugs directly into the central circulation. So a corollary of that is the fact that if we are injecting local anesthetic agents intraosseously through using a device that perhaps makes a perforation in the bone that then allows us to connect a dental syringe to that perforation, we do have to be cautious that we're going to get a higher systemic response. So in that situation, again, I would use a very slow injection technique, probably a half of a cc over about 30 seconds, so that we're avoiding getting a rapid rise in the systemic concentration of the local anesthesia. So here's a good question. Why does